In September 2009, a 23-year-old male collegiate football athlete, fractured his right clavicle during preseason football practice. The athlete was completing a pass route when he went airborne and fully extended his body and shoulder in an attempt to catch the pass. He landed on the tip of his shoulder, sustaining a direct blow. Unable to support himself, the athlete was escorted off the field by sports medicine staff for injury elevation. Field evaluation by the athletic trainer ruled out a shoulder dislocation, which the athlete had reported in a medical history. Point tenderness and gross deformity along the medial shaft of the clavicle and serpitis, and swelling over the fracture site were apparent. The clavicle was elevated immediately due to sternocleidomastoid muscle span and depressed laterally as a result of the pull of gravity on the glenohumeral joint, as well as the pectoralis muscle span. Neurologically, examinations was within normal limits for both motor and sensory nerves. The patient was then referred to the team orthopedic physician for further examination. Radiographic examination revealed a closed mid-shaft comminuted fracture of the right clavicle with shortening of 2 centimeters. Operative and non-operative options were carefully discussed and surgery was elected. Anterior-posterior radiograph showing mid-shaft clavicular fracture. Note surgical anchors related to the previous shoulder stabilization. Internal fixation of the right clavicle with plate osteosynthesis was performed. Plate osteosynthesis was chosen over intramedullary pins due to the plate's ability to resist greater torsion and no risk of pin migration. Also, plate osteosynthesis results in less displacement at fixed loads and provides a stronger construct, allowing early rehabilitation. At the time of surgery, a large butterfly fragment of approximately 2 centimeters off the anterior aspect of the mid-clavicle and a spiral oblique fracture were noted. The butterfly fragment was fixed with a 3.5 millimeter intermagnetic screw, reducing the fracture to 2 parts. The fracture was reduced and secured with the superior plate. Given the length of the fracture, the superior plate was used to maximize strength and stability. Allograft demilitarized bone matrix was applied along the fracture line to promote healing. Radiograph showing plate osteosynthesis. Radiograph showing 3.5 millimeter interfragmental screw. Discussion. The fracture sustained in the case was a type 1 mild third of the clavicle, which is considered the most common site for clavicular fractures. Mid-shaft clavicular fractures account for 69% to 82% of the clavicular fractures. In the past, non-operative treatment was the norm based on reports of rare non-union episodes. The recommendation for type 1 clavicular fracture with shortening was a conservative approach for 6 weeks, and then if no calcus had formed, surgery was indicated. However, the treatment of the clavicular fracture has changed drastically in recent years due to the current trend of non-union rates in non-surgical management, open reduction, and internal fixation, ORIF, has become readily accepted in the clavicular fracture management. The athlete in this case sustained the fracture to the middle third of clavicle secondary to a direct impact on his right shoulder while diving to catch a pass. He opted for surgery instead of non-operative treatment, consisting of sling immobilization for 2 to 6 weeks. The ORIF was performed immediately, and the athlete returned to full competitive contact within 6 weeks. Previous timelines for regaining full range of motion. The fracture after surgery were unclear. We present a successful ORIF, surgical repair, and specific timeline for return to fractional competitive activity. Conclusions. Traditionally, a athlete undergoes traditional treatment for a clavicular fracture would have been immobilized for 3 to 6 weeks before any range of motion exercises were started. However, in the past few years, more aggressive treatment protocols for clavicular fractures have become popular. Since successful rates of 94 to 100%, with low rates of infections and complications have been reported with plate fixation of acute mid-shaft clavicular fractures, and intermediary nailing using titanium elastic nails has also evolved. With surgical treatment and appropriate rehabilitation, our athlete was able to return to competition at 6 weeks without compromising his health or safety. The rehabilitation protocol implemented in the case was advanced, yet evidence on validated accelerated rehabilitation protocols for clavicular fractures is currently lacking. As surgical repair for clavicular fractures become more frequent, we need to investigate new rehabilitation protocols.